for the next lecture. I will present now this is Professor André Teixeira. Professor André Teixeira will talk on observership, bedside training as a robotic fellow and established surgeon. Professor André Teixeira not only is a very good friend and very old friend, but he's also a robotic and bariatric surgeon in Orlando Health Weight Loss and Bariatric Surgery Institute in Florida. And I think he's running, I'm not sure what I'm going to say, but I'm almost sure maybe the highest volume robotic bariatric surgery center in the world now, I will say. So, André, thank you very much. And you can start.
Thank you for the introduction. I think Gloria has my lecture because I'm in between. I'm doing a trial here now with magnets too. So Gloria has my lecture, so I'll stay also on for questions. She's going to play the lecture. Gloria?
How training robotic surgery from observership to a robotic fellow and then subsequently to established surgeon. Let's see if I can be able to deliver that. Because as you guys know, I'm a robotic surgeon. And at the time, there was really not a robotic training. It was everything we learned. We learned as we trialed and so forth. And my path was with a different system. And we had to take stepwise. There was really not a way to do courses. There was really no observership or training or anything like that. Everything at that time was dedicated to general surgery. But anyway, it worked. So let's go. So this is a learning curve path, right? For you to get to the expert level or good outcomes level, you have to start somewhere, right? And then you have to dive in head first, no questions about it. For you to do a progression on your learning curve, even today, I still make little changes on the way I do the procedures that the more I do it, I see some difference in outcomes and some difference in time and so forth. This is my learning path on the switch up to 2023. I'll say the switch I'll include it here. Bypass and then sleeves, right? I didn't put revisions because revision is very tricky. Revisions you have to, there's some cases are longer, shorter, just really depends on what you're doing. I don't consider a sleeve to bypass a revision. I think it's just a conversion. It's one procedure to another. Half of the procedure is already done. So that it would be more difficult for me to kind of give you a learning curve on a revision perspective. But for you, again, you have to dive in. Dabblers that only do one case or once a week, and then the other, they do lab or they do open, whatever it is, they're never going to progress or pass that learning curve perspective. To make it an expert, I always think is a really good thing that shows that outstanding performance is the product of years of deliberate practice and coaching, not of any innate talent or skills. For you to become better at it, right, you have to practice. I'll give you an example. In America, we pretty much have the intuitive systems, right? Recently, we started getting approval FDA, CMR, Levit, and so forth. I've been to another system, done some cases that couldn't really tell the difference, right? in between. As we thinking in systems, doing the case, it was very similar to me. But why? Because I've been exposed to different things. So for you to understand that, you still to immerse yourself into this new pathway. You have to start by introduction of robotic, right? I mean, it's a 13 billion reach if you think about it by 2026. It's a big market, right? Intuitive alone has done 12 million cases and expected to be more, right? I think the competition is going to be bigger the next 5-10 years, which is going to be beneficial for us. Robotics are here to stay, no questions about it. Like, for example, our hospital, we have 26 XIs, 3 ions. I think we bought 2 DV5s now. And then we have, you name it, in terms of neurosurgery, vascular, plastics, robots. We have pretty much almost everything. So the hospital itself is very deep in technology. We are looking at patient outcomes. If it makes sense to enhance patient outcomes, why not, right? It is well known the data. If you compile the data, the meta-analysis shows that robotic surgery results in 50% less blood loss, right? Reduced pain, faster recovery compared to traditional methods. Technology advancement, no questions. AI, I mean, now you have AI in your telephone and so forth. So AI is going to become part of it. The DV5, for example, data analysis is pretty impressive. You get your report hours after you finish your case. So the analysis is there, and it helps you to guide you in a different way. I foresee the AI with the robot and the surgeon, the AI will kind of hopefully guide and develop a pathway to guide the new surgeons in training. Of course, it starts with observership. I think before that, it starts with the curiosity in terms of the technology and trying to figure out something different and better for you and for your patients. Observership is always a great way to start. I think you go and see people, you learn the workflow. What sometimes people forget, they come in just to see the surgery. You should look at everything, how the whole OR interacts with the system, how the workflow is done, how is the OR versatile in technology, and build foundation skills. Those are very important. And then you have include talking to senior surgeons, discussing ideas, methods, how they approach it, why they approach this way, simulators. It's a good way to start too. And then they usually ranges between days and months in time frame. It depends on how much you have an opportunity to observe others. And then you have to do your basic robotic training certification, right? That's how you start. Usually it's a hands-on skill development for you, junior fellows, or in this case, in the United States, depending on which program you are, you're already starting your residency. Most of our resident body here, by the time they are 4th or 5th year, residents, they are so versatile in robots, it's pretty impressive. We can actually see, especially when I have fellows that come in that have come from programs that are not really deep into robots, there is a huge discrepancy in learning curve with their perspective. But in skill acquisition, you're going to perform basic robotic tasks like camera control, suturing under supervision. You have to, the red things I think are important to me, engage in hands-on training, often begin with minor procedures, assessing assisting senior surgeons, with docking, undocking, camera, exchange of instruments, gradually moving forward in your tasks when you're in the console. Learn about preoperative planning, post-operative management, and then give a certificate in a course. It depends on which you're doing. If you're doing intuitive here, you get a certificate right away. It's a 1 to 2 day course, depending on what level you are. But then the development of those junior skills, if you're involved with a program, it can be 6 months to a year. That's usually what we see the traditional for our residents and junior fellows. Then a fellowship, like with the fellows come to our programs to do robotics and bariatric. Some of them, like I said, have done much in robots, so there's a whole process to it. You start before hopefully teaching a little more complex. Sometimes you have to start from the basics, which is like how to control the camera, change your instrument force, right? That's a big thing. The DV5 now you have force feedback. So for new trainees, I think is great. But for older surgeons that have been doing robotics for many years, I'm not so sure that's worth it. But still, there's a different data point that we need to figure out. So you start assisting gradually perform robotic surgeries under guidance and expertise, developing proficiency, which is very important. I think I tell them is avoid waste movements. That's one of my pet peeves. Perform increasingly complex parts of surgeries, managing complete cases from preoperative assessment to post-op follow-ups under supervision, of course. Then, okay, this fellowship is really focusing on honing your skills, get you better, specialize in your field, like for example, as bariatrics. Of course, the fellowship is 1 year, but usually after that, and depending on where you are, if you're in a very busy program, 1 year is more than enough. Our fellows here finish with about 500 cases each, so they're super well trained in terms of robotics. And then you have the mentorship, proctorship, right? Transition to independence of your practice. So once you move to that practice, you've done here already all your training. Now you try to figure out how to become a mentor or proctor, right? I mean, you mentor overseas complex cases, providing feedback and refining techniques and decision-making skills. I'm always in the phone exchanging ideas with different people, different cases, request for assistance, for help, discussion. We use technology now to kind of jump in the cases and help them out. It typically lasts for about several months to a year, depending on your skills or confidence level. And I think it's important for us to understand where the future of training is coming to. I think AI is going to be a big part of it. What I talked to you a little bit was more traditional, but I think this is what some of the things we're implementing now. AI enhanced precision, allow AI to allow real-time diagnostic image guidance, navigation, heighten your surgical experience and precision. So I think that's where AI is going to need to go, the system. The expanding autonomous capability, that's going to be interesting. I think with the AI and that capability allows you to correct the movements as the surgeons is trying to do the case and having difficulty. It kind of guides you. And then virtual reality, I think virtual reality is huge because it allows you to see some different paths even before you do the surgery. It allows you to kind of do the procedure without doing the procedure, have an idea of your work frame, where you're going to go. Of course, all that has to do with 3D reconstructions and so forth. Hands-on robotic observation, where you're going to jump in from one system to another from different places, which that'll be a great way to do the hands-on observership. VR simulation, as we talked about, customized learning pathways. Depends on what you want to do, where you are, what specialty we can customize and assess that too, with all 3D guidance, VR, simulation labs, and AI. And then the same thing, it's just in skills and certification is going to be a lot different. In my mind, you still have to do that basic part, but now you're going to have more simulated hands training. I think the simulation is getting better and better and better. You're going to have AI-assisted skill assessment, which allows the real-time feedback and repeating or changing the difficulty of the scenarios so you can pass different scenarios. And then certification is going to be almost the same thing, but just with the AI and the enhanced simulation component. Same thing with futuristic mentorship and proctorship. You're going to have an AI augmented feedback. No questions about it. That is coming down pipeline. A virtual core surgery. That's some of the things I think about it. My head is out there. The virtual core surgery would be like almost like a pop-up and tells you, hey, I think we should do this, we should do that. some kind of theory for that matter. Proctoring, teaching role models, same thing. Proctors leverage VR and AI to guide junior surgeons, establish standards of robotic excellency. Of course, a lot of these things were my ideas come out of my head. Hopefully this can become real. Advanced autonomous assistance, it kind of help you and guide you on all your procedures. Like we talked about it, continuous learning is innovation. This is important, right? I think for you to become a very successful independent robotic practice and leader, you have to be part of innovation, research, continuous advancement, contributed to the field. I think is a big thing, right? Contributions, pushing the boundaries of robotic surgery, like different things like we're pushing now. Recently, we started using 1.9 millimeter orthoscope to do some laparoscopy diagnostic things. So it's 1.9 millimeter, right? So looking where it's around you and trying to push a little bit more the envelope. The final path, again, achieving expert status, contributing to the field of training others, because it's a pretty honor situation for you to be able to be part of that and do that. Leading robotic surgery programs, becoming a proctor, mentor for junior surgeons, publishing research, presenting at conferences, and possibly develop innovations and techniques in robotic surgery. Advocating for best practices and safety standards in robotic surgery. Again, this is an ongoing duration. I don't think there's an end to it. I think the day that I feel like I don't have anything else to contribute anymore, that's the time for me to retire. And hopefully this is a long time away from now. But this is what I see from an education perspective. I did not have none of this. I wish I had it. But the people coming now are going to have a lot of this stuff, and it's going to make them a better and a safer surgeon, no questions about it. Thank you very much for the opportunity to participate here. Open for any questions now.
Andre, thank you for your talk. Very nice talk. And I had a thought, and I wondered, I wanted you to weigh in on it, and also I'd be very interested, Dr. Rogers, in your thought, given your position within ASMBS. But it's really exciting to me to see the advances in mentorship and proctorship in terms of what's going to be allowed, because historically it's been tremendously taxing in terms of time and effort, especially to mentor people outside the country. It's a lot of time you have to take away from your practice, and a lot of that is going to be done virtually. And the other aspect of that is that we're kind of in a select group, but there are a lot of surgeons out there that don't have somebody they could just pick up the phone and call. So if I ever had a problem, I would just pick up the phone and call Kelvin, and he would always know the answer to everything. So that was like my go-to person. What are your thoughts on, like, if societies created like a committee of people that were very experienced, that were just available to the community, and it would be a group of people, and I think the technologies will be there where you're in the OR, you have a complicated situation, you could link up, but basically providing a group of people that they can reach out to, and that would be available for everybody.